Good morning, everybody. At the outset, I would like to thank Professor Kato and Professor Azmi and also Professor Lawton for having given me this opportunity to be here in this wonderful Congress, even though I could not be here physically, but at least being allowed to give my lecture online and also listening to the wonderful lectures online. So today I'm going to speak about my journey for about 20 years, which is my experience with severe basilar invagination and Atlanto axial dislocation. So in the institute where I work, we do about 100 to 150 cases of cranio-vertebral junction anomalies a year. And most of them are really complex cases with severe Atlanto axial dislocation and basilar invagination, consisting of very complex bony anomalies. And I would be particularly speaking about innovation of my own techniques for this pathology. So the question, these are the kind of pathologies which we see. They are really very severe pathologies. The question is, how do we tackle them? Are we bound to do a transoral excision followed by posterior fixation, or can we reduce these deformities by a posterior only technique? And that is where I will be describing my technique of DCER. So the DCER technique, in other words, is called as distraction, compression, extension, reduction, is something which I have developed over the past 15 years. Now, if you look at cranio-vertebral junction, the cranium is balanced on the cranio-vertebral junction more delicately than the globe was balanced on the head of Atlas. And for a long time, we were seduced by what we saw in the midline, that is the compression of the dens over the cervicomedullary junction. And we ignored what was there on the sides, which are the joints, which are the key factors for stabilizing the cranio-vertebral junction. And of course, the credit goes to Professor Atul Goyal, who for the first time described the C1, C2 fixation and also mobilization of the joints. And this lecture would briefly demonstrate the technique of DCER, which stands for distraction, compression, extension, and reduction, with its various algorithms and modifications. So the first component of this innovation is to add a motion in the sagittal plane. So earlier what was described is just putting a spacer and putting a C1, C2 joint, but there was no description of reduction of deformity. Of course, as a consequence of putting spacer and putting C1, C2, if it reduced, it's well and good. But some of these deformities are very severe deformities and they don't require some kind of intraoperative manipulations to reduce it. So this is the fundamental principle of DCER, where you put a spacer in between the OC1 and C2 and apply compressive forces between OC1 and C2 in order to reduce not only just the Atlanto axial dislocation, but also the residual basilar invagination. And that is summarizing the fundamental technique of DCER. The whole idea is to increase the height of the spacer in order to increase the lever advantage. So whenever we have very severe anomalies, we tend to increase the height of spacer, because you have to understand that if you increase the height of spacer by 1 time, it would give you a lever advantage multiplied by 5. The next most important discovery here was the description and discovery of a pseudo joint. So whenever we look at very complex anomalies where the C1 arch is fused and there is a basilar invagination and Atlanto axial dislocation between the OC1 and the C2, we come across such complex anomalies which are seen on the sagittal sections of the CT scan. But it is an anatomical surety that if you have a true joint, in this case, this is a true joint, you do formation have a false joint, because the true joint cannot bear the entire weight of the cranium. So we have described 2 types of pseudo joints. Type 1 is where you have partial true joint and partial pseudo joint. And in type 2, the true joint is totally vertical, and hence the weight of the cranium is completely borne upon the pseudo joint, which is formed by the proximal and the superior surface of the C1 pars. C2 pars. We deal with a lot of congenital anomalies. Most of these cases have a fused C1 arch with basilar invagination Atlanto dislocation. And one of my PhD students started studying these cases. And by doing the study, we found that a majority of the patients have mutation hits at the FPN1 gene, which is the same gene which encodes for Marfan syndrome. So in essence, most of these patients have this partial Marfan syndromes, and we postulated a new hypothesis stating that presence of inclined joints along with weak ligaments is what leads to progressive slipping of the dens upwards and backwards. Now, is there any role of transoral odontodectomy as of today? Definitely there is a role. So if you look at conditions like clival segmentation anomalies like this one, obviously we need to decompress the dens from anteriorly. And of course, whenever we find infective or destructive pathologies, we do have to do a transoral decompression. Now, this was the first paper where we described the technique of DCER, and we have done more than 300 cases as of today. And these are few of other papers which have been published, and you could go through them. Again, few of my other papers. So how do we do it? So you have to understand that when the C1 arch is not occipitalized, you go ahead with a straightforward C1, C2 fixation. That is, there's no question about it. And that's very easy to reduce. It's not very difficult. You just need to put a C1, C2 spacer and with or without spacer, and then it reduces. But what I'm talking about are the conditions where the C1 arch is fused with the occiput. So what do we do in such cases? So this is such case. You can see that the C1 arch is fused, very severe compression. There is practically absence of the cervicomedullary junction. So that is where we bring in the technique of DCER. So the fundamental problem here is that the dens is progressively slipping inside the skull and moving backwards. And the reason is that these joints are inclined and have weak ligaments. And we need to prevent a sad story of transoral excision. We need to reduce them as shown here using a posterior only approach. We also described the technique of extra-articular distraction, which means that whenever there is formation of a pseudo joint, because of the true joint becoming vertical, we use a spacer in the true pseudo joint in order to provide a complete reduction of the deformity. So in this case, you can see that the true joint was vertical and the pseudo joint is present here. So we put a pseudo spacers in the pseudo joint in order to reduce the atlantoaxial dislocation and the basilar invagination. So this technique is called as extra-articular distraction. We also described some new kind of instrumentation where using a spacer, we could connect it to the rod in this manner. Now, we also felt that there was a need for us to push the C2 forward. The reason is that we found, again, not described earlier in literature, we found that whenever there was a severe basilar invagination with atlantoaxial dislocation, even if we reduce it, putting a spacers and apply compressive forces, there is a significant gap between the OC1 as well as the dens. This is because in severe cases, there is a backward retrolisthesis of the dens. And that is the reason in order to reduce the backward retrolisthesis, we need to apply pushing forces at the level of C2 in order to push the dens forward. This, of course, is a photoshopped image, but this is what we would have liked in this case when we did it. So that's when we started working upon this universal reducer, and we patented it. And this is how this reducer looks like. So fundamentally, what it does is it has a wiring mechanism which reduces the atlantoaxial dislocation after we put in a spacer. And it also has this screw which pushes this pivotal mechanisms on the C2 so that the C2 moves forward. So this is an example. So this is an earlier case where we did not have a universal reducer and we were not able to reduce this gap here. But now when we came across a similar case, we use a universal reducer and you can see we were able to push the dens very nicely forward in order to reduce the gap between the OC1 and the C2. So this is, and we also found that whenever the reduction was not adequate with one size of the spacer, when we increase the height of the spacer, as in this case, we were able to provide a better mechanism for complete reduction. So that's the pre-op and post-op. Finally, the story of universal reducer, which I've already shown a few slides. This is how it looks like. I've already shown it to you. And using this is an example of a very severe BI with AAD, a child who underwent some kind of useless wiring outside. And in this case, we were able to use the universal reducer by putting the spacers and pushing the C2 forward, not only to correct the basilar invagination and AAD, but also to correct the hyperlordotic cervical deformity. Now, DCR leads to solid fusion. So whenever you immobilize the cervical spine completely, you provide a fertile bed for very good fusion of the bones, and that is what has happened here. And not only that, DCR creates a plumb line correction. So in our studies, we have shown that there are correction of all the spinal curvature parameters, and this has already been published. Another pre and post-op image, another very severe AAD with BI, practically the dens is going backward in a horizontal direction, causing severe compression of the cord. And again, using the universal reducer, we were able to provide a very satisfactory reduction. I will skip the video for the lack of time. I will finally end with this case. This is a 32-year-old female who fell from a tree about a couple of years back, developed spastic quadriparesis, and then improved, had severe spasticity. Believe it or not, she came walking. Even though she had severe spasticity, she could walk with support. And this is what she came. So what it shows is a old fractured dens over here. So how would we tackle this? So theoretically and logically, we would think that we will have to do this from the anterior part by removing the dens. But in this case, we used a modification of the DCR by which we were able to reduce it from a posterior only approach. And that is the new technique which we described, whereby in cases of old fracture of the dens with such severe compression, which we not uncommonly see, we have operated about 34 cases like this. Here we drill the C1 lateral mass completely and put a spacer between the OC1 and the C2 joint. And this we have published in this paper. So as you can see, we remove the C1 lateral mass and the C1 arch completely and place a spacer there so that this spacer now articulates with the occiput as well as the C2. So I will end my talk here. So this is a few minutes summary of my 20 years of journey. And it was indeed a bit difficult for me to wrap it up in 15 minutes. But it has taken me to a lot of places. It has helped me to strengthen old ties and make new friends like I'm going to make from ISMINS. And this, of course, was an oration which I gave in South Korea, and that was a wine bottle which was released on the occasion of the paper which was published in Neurospine. So thank you very much again for this opportunity.